So good morning, everybody, and thanks for having me this morning to speak on this topic. I'm hopefully going to be able to provide everybody with, hopefully a pretty thorough understanding of how to manage small testicular masses that you might find in your patients in the adult population. And for the purposes of this presentation, it's important to note that the data that I'm going to be showing and going over really only focuses on the adult population, as there's certainly some variance between how we manage these masses in adults and children, especially given the differences in pathology that you might find between a pediatric and an adult who present with a small testicular mass. So before we delve into the topic of small testicular masses, let's look at all testes masses, both palpable or not palpable, and they affect somewhere between 4 to 8 men per 100,000. What's important is that if you can feel a mass on a patient, there's likely a very good chance that it's malignant. Some case series and cohorts report that if they could palpate a mass and look at the final pathology, about 90% of palpable masses in a testicle ultimately do turn out to be germ cell tumors. And in that remaining 10% of palpable masses, malignant, etiology still exists. So you could have a metastatic lesion, you could have a non-germ cell tumor, or you could have, a benign tumor that is actually palpable. But this morning we're going to be talking about a different scenario, which is a small testicular mass. And we're going to walk through the diagnostic and sort of treatment dilemma that occurs with an incidental non-palpable mass. But we should really get some definitions sort of clearly outlined first. And within the small testes mass world, we're still kind of in a relatively early phase of understanding, and a good definition still sort of eludes us. Most clinicians will probably define this as somewhere between a 2 and a 2.5 centimeter mass. If you look at some of the big governing bodies in urology, like the AUA, EAU, and CUA, the EAU and CUA don't actually give specific criteria, although we'll talk a little bit later about what they do say about these small testicular masses. But the AUA kind of gives us the most clear description, suggesting that they should be defined as something less than 2 centimeters in their most recent testicular cancer guideline. What's important for us is that it looks like these masses typically become palpable when they grow to be about, greater than 0.5 centimeter. So if you can feel a mass, the general rule would be that it's at least that size or greater. And these size criteria become important later when we try to risk stratify some of our patients to decide what we should offer them. So if these masses, and if many of these masses aren't palpable, then how are we finding them? So we've seen a rise in the use of ultrasound that's likely due to its increased affordability. The probes are also getting very sensitive. So right now, most standard ultrasound probes have a sensitivity approaching about 100% for picking up a testicular mass. And we can pick up small masses, so we can pick up anything basically greater than 1 millimeter. So if there's a mass there, we can pretty much find it. Where the dilemma sort of crops up is that these ultrasounds are very poor from a specificity perspective. So we can find that mass, but we really can't differentiate it between malignant and non-malignant. So this makes it difficult for us as clinicians because we get these referrals, we get a testicular mass identified, but we don't know what it is. And then we have to decide what to do with it. This picture here is more for our fifth years who are studying for their exams because it's a really good visual recognition question with the spot diagnosis of an epidermoid cyst with that onion skin-like appearance. So if ultrasounds are picking up these lesions and they're incidental, then why are we ordering the ultrasounds? Because if they're incidental, by the very nature of that, means that we weren't looking from an oncologic perspective for these patients. So why are we doing ultrasounds on men who we don't suspect cancer in their testes? Well, it's becoming increasingly common that a testicular ultrasound is being recommended for really any benign scrotal issue. So just two examples here. This is just a cutout from the CUA scrotal pain sort of position statement guideline that lists scrotal ultrasound as one of the optional tests you can do for a gentleman presenting with scrotal pain. This is a cutout from one of the large infertility guidelines out of the US that lists, imaging of the scrotum for men presenting with infertility. And I can say, anecdotally, having worked at a couple centers in their departments where they're screening infertility patients, there's lots of centers that if you show up for, male infertility, you get a scrotal ultrasound ordered regardless of your presentation. In one large cohort that looked at about 4,000 guys showing up for male infertility who had a scrotal ultrasound done, about 3% of those guys were being found to have a small testicular mass incidentally found on that ultrasound. And so I'd also probably say that most men presenting, to an emergency room or probably with any type of scrotal complaint are probably also undergoing an ultrasound. So this has really been sort of driving the diagnosis of these incidental masses. So now we know how and why we're picking up some of these incidental small testes masses. Uh, but is there a population who gets them? Is there a certain demographic that may be actually having these occur, so that we can actually risk stratify our patients or find a group who's more likely to get them? As I mentioned earlier, they're not uncommon in the pediatric population. We won't really focus on that today, but very generally, they more frequently occur in pre-pubertal males. Unfortunately for us, as adult urologists, these patients are the same guys who are getting germ cell tumors. So there may be a very slight trend towards men who are getting small testicular masses, that they may be occurring later in their 30s as opposed to earlier in their 30s, where it might be more likely that they have a germ cell tumor, but not to the point that you would be able to change, your clinical management of the patient or screening recommendations. So unfortunately, at this point, we have really not identified any clear risk factors for the development of specifically a small testes mass. And so right now, we have to basically treat them all the same. So to hopefully make how to deal with incidental masses clear, I thought we could walk through a case and discuss some of the evidence behind each of the decisions that we would make for that person. So we have this, anonymous patient of ours who's a healthy 30-year-old who's had testicular pain ever since he was involved in an accident. Fortunately, he also has a history of solitary testes secondary to cryptorchidism and orchiectomy in his teenage years. His family physician was quite dutiful. They did tumor markers, which are normal, and they come into your office and you can't palpate the mass. So what should we do now for this person? Well, I think first we should always make sure we have all the pertinent information. So right now there's no guideline that actually touches on what is the mandatory workup for a small testicular mass. But most clinical series and sort of cohorts that have gone on to surveil some of these masses that I'll talk about in a minute would agree that you basically complete a workup very similar to a testes mass that would be concerning for cancer. So everyone gets a typical history and physical examination. Everyone should probably get tumor markers up front. And then kind of by definition, they've already had an ultrasound, but make sure that they've had an ultrasound. What's controversial is whether or not these gentlemen need a CT scan. So most of the series that have looked at small testicular masses did not do routine CT scans for these men as part of oncologic staging. And certainly, our practice so far here in BC has not been to, routinely CT scan someone unless we were concerned from a staging perspective. But we could certainly discuss this a bit more at the end of the presentation. So I'll say for our case, I think our initial workup is complete. And now we can think about what we should do for our patients. So, what should we offer them? Surgery, surveillance. And I think before we sort of dive into the treatment options, I think it's important to figure out what is his risk from this. So remember, he has a sort of 0.4 centimeters, a 4 millimeter mass, negative tumor markers. And there's really been no one large study that's been done to try to answer the question of what is the natural histories of small testes masses. So I've had to amalgamate some of the larger studies, and by large, I even mean sort of 20 and 14 patient cohorts. They're not quite large, to try to answer that question for us. So the largest group, which is this group of 120 men, comes out of Toronto. Keith Jarvie there was the one who did this and is kind of one of the foremost experts on this. And so he had looked at a group of about 4,000 men who had presented with infertility. 120 of those men who had had an ultrasound had been found to have a small testes mass. A couple of them, 16 went for immediate surgery. This was because of concerning findings on those ultrasounds. And then about 104 went on to surveillance. 2 subsequently ultimately went for surgery as well. And these 2 were actually found to have a malignancy, a seminoma as well. They didn't have particularly long follow-up, about 1.5 years on average of follow-up for these men, but it's the largest cohort that we have to go on right now. What's important in these studies is, although malignancy was found at a relatively low rate, no cases of metastases were noted, albeit this was a short follow-up, in any of these sort of cohorts. These other small cohorts were mostly looking at even smaller masses that were picked up incidentally. So these guys were a group of infertile men who underwent an M-TESE and had a subsequent mass noted. 0 of those men were found to have any malignancy. And this was a group of 20 guys who underwent partial orchiectomies for less than 5 mm masses. This was more of a general urology population rather than a specifically infertile male population. And they did find 4 cases of germ cell neoplasia in situ. So no overt malignancy, certainly some features of malignancy in 4 out of 20. All of these studies really need to be taken with a bit of a grain of salt, as there's probably several biases and study design limitations that are preventing us from accurately coming up, with a true, the risk of malignancy of a certain size small testes mass. There's obviously a selection bias probably going on with those men who are being offered definitive surgery up front with worrisome features are not being included in these cohorts. They reported their malignancy rate as sort of 6 out of 120. Although I don't think that's entirely accurate to say, is we only really have pathology on about 18 guys, so 16 immediate surgery and 2 with delayed surgery. And the rest of this group, we really don't know what their pathology was. So I don't think we can fully answer that question. What I hope looking at these sort of small cohorts does show us is that we can say with a little bit of confidence that the risk of malignancy in an incidental mass is low. Although an exact percentage to be able to tell someone is probably escapes us currently. So of the guys who do undergo surgery for small testicular masses, what is their histology? So do we find that they have malignancy? Do we find that they have benign disease? The vast majority of them, so 70 to 80% across all case series, show that these end up being sort of late egg cell tumors, which the vast majority of those late egg cell tumors are typically benign, looking at 95% of those being a benign mass. Other common etiologies can be sort of rare things like an epidermoid cyst or something really rare like a Sertoli cell tumor. What's interesting is if you look at the malignant histology, so for men who actually have a diagnosed germ cell tumor, by far the most common is seminoma. And I think the thought here seems to be that this is the most common pathology, probably reflecting the relative difference in growth rates between seminoma and non-sem, where seminoma does tend to grow a little bit slower, perhaps giving us more time to diagnose it sort of in this incidental phase. Maybe non-sems progress faster, they either become palpable or you do find them incidentally, they're larger on ultrasound, so they're not being included in these small surveillance cohorts. And so it ends up being that we find them all to be seminoma when we actually do surgery on them. So back to our case. So to summarize for this gentleman, we have a 0.4 centimeter, 4 millimeter incidental testes mass in a solitary testis. So the question becomes, what do we offer this gentleman? And the options can be, orchiectomy, partial orchiectomy, or potentially active surveillance. So if he wanted the most definitive treatment, he could certainly undergo an orchiectomy, but as I've made this scenario a little convoluted, he has a solitary testes, so we'd be immediately rendering him, hypogonadal, and if it ends up being benign, we've certainly not helped him. Partial orchiectomy could be offered. We'd give him maybe a better chance of maintaining some testicular function, but again, if this lesion ends up being benign, we've certainly not helped him. And the last option would be active surveillance. Now, we know from some of these cohorts that the majority of these masses probably don't grow that much, even over this sort of short follow-up that they have, but it certainly can help avoid intervention in the vast majority of men. So for this young guy with single testicle, perhaps watching and waiting might be the best option for us, so sort of moving forward. So let's say we offer this guy active surveillance. How do we now surveil them? Well, as I mentioned, it appears that these masses really don't grow. So growth rate is something that we can probably track moving forward to watch and intervene on. But first we just want to make sure that he meets some of the sort of reported criteria out of these case series that they used to enroll their patients into their active surveillance protocols for these small testes masses. So this is pretty much the same over these small case series of men who have had or have been enrolled in active surveillance. So most studies would say that we don't enroll someone who's got a mass that's larger than a centimeter. They should all be non-palpable. And if they've had tumor markers evaluated, obviously those should be negative or normal. If they meet this criteria, then we can move on to actually surveilling them. So we can ultrasound them at, 1, 3, 6, 12 months. And then if there's been no growth, we can just do it annually thereafter. And then what are we watching for? Well, we're watching to make sure that they still meet this criteria. So if any of these things change, then we can defer immediately up to surgical intervention. The growth rate that that large cohort out of Toronto, or the largest cohort out of Toronto, showed was a millimeter per year was their cutoff. So as long as you didn't grow more than that, you were okay. In terms of no new concerning features, so one of the concerning features that's most frequently listed is vascularity on ultrasound noted in these testicular masses. It doesn't look like it's a great predictor of malignancy. There seems to be a trend that obviously a malignant mass probably has more vascularity. In that cohort out of Toronto, of the masses that were noted to have vascularity that subsequently did undergo surgery, only about 30% actually had malignancy. And so it's not something that is particularly predictive of malignancy. So let's say our patient's been enrolled in active surveillance. He's shown up for his ultrasounds. He comes for his 6-month follow-up. And unfortunately, his ultrasound shows that his mass has grown, from 0.4 centimeters to 0.6 centimeters between that 3 and 6-month ultrasound. So, based on our reported protocols, he's now failed his active surveillance with this increased growth. And so maybe we should now actually move towards definitive therapy. One of the interesting things in these case series, and most of these case series are written by infertility specialists, because we're the ones doing these screening ultrasounds and finding these men, is they don't really touch on whether or not repeat staging should be done. Even something like repeat tumor markers should be done ahead of any surgical intervention. They kind of will vaguely state, if you're quite concerned about malignancy, you should think about doing it. I think certainly if you're thinking about surgical intervention for these gentlemen, I would certainly never operate on someone without preoperative tumor markers. It's a pretty benign test to order. So I think it's very fair to repeat this should someone be failing surveillance and moving on to surgery, as the minimum of repeat staging to be done prior to actually intervening. So let's go back to our little decision tree here. So now we've updated this a little bit. Let's say he now has a 0.6 centimeter mass in a solitary testis. Let's say, for the sake of argument, we repeated markers, they remained negative. So looking back at our options now, really we've moved away from active surveillance and we're looking more towards orchiectomy or partial orchiectomy. So why shouldn't we just offer this guy an orchiectomy? He's had sort of concerning growth features on this small testicular mass. It's certainly a simple, a very definitive solution to any testicular mass. Well, in this case of this gentleman with a solitary testis, of course, we'd be forcing him into a state of immediate, hypogonadism, certainly infertility. However, I've made this a bit of a unique case with a solitary testis. So should we still shy away from an orchiectomy? Let's say if he had a healthy contralateral testicle. As I think most of us would consider, an orchiectomy, if you have a healthy contralateral testicle, to be, hopefully from an andrology perspective, a relatively benign procedure, meaning he should have normal, testosterone production, maybe normal fertility afterwards as well. However, in some of the case series that have looked at men who have undergone orchiectomy for all causes, so not just malignancy, but things like torsion, or they were born only with a single testicle, we do seem to see that a unilateral testicle is related to reduced spermatogenesis, altered endocrine function, and ultimately reduced male body image. So there are some negative side effects of just jumping straight to an orchiectomy, even if someone has a healthy contralateral testicle. Furthermore, in a situation such as this, where we've seen a bit of growth in this small testicular mass, could he still have a benign lesion? And the answer is yes. In that large cohort out of Toronto, of the 18 patients who underwent surgery for a mass that had concerning findings, only 6 ultimately ended up having a malignant origin. And so it's very possible that in this situation, this gentleman could still have a benign lesion that just has grown a little bit. So perhaps our case is better served with a partial orchiectomy, especially given that he is a solitary testis. So what do our guidelines say about offering partial orchiectomies to men, as this is somewhat of a rare operation? Well, both the EAU and CAU guidelines state that this can be offered in situations where you'd essentially be taking either both testicles or leaving them with no testicles. So bilateral tumors or tumor in a solitary testis. The most recent AUA guidelines probably give us the most clear guidance about this. So they define these masses as less than 2 centimeters. And you can offer partial orchiectomy to men who have these small testes masses who are wishing to preserve some type of gonadal function in these same scenarios of a solitary testis, bilateral tumors, or similar to our case, an equivocal ultrasound with normal markers. So this probably gives us the best guidance as to what to do in this scenario. So let's say we wanted to offer this to our gentleman. This is basically the classic decision making that you would make if you were doing a partial orchiectomy for someone while you're in the OR. So you start your partial orchiectomy, you find your mass, you send off intraop frozen sections. If it comes back negative, meaning that they don't believe that there's any cancer there, we say great, we continue the partial orchiectomy, close as normal, and we go from there. If it comes back positive, meaning that we think there's a malignancy, we would do a completion orchiectomy on that person. Unfortunately, this approach doesn't take into account some of the sort of nuances of patients who are undergoing partial. They're usually being offered this for a specific reason, such as our case with the solitary testes. So if you were to do a completion orchiectomy, in that case, you would render them without any remaining testicular tissue. So perhaps you can have a bit more nuance to that intraoperative decision making. So this is sort of the more updated version of what type of decision making we're doing when we're doing these procedures in the OR. So let's say we've gotten to that point where we have a positive intraop frozen section, and then we look at the patient and we say, do they have a healthy contralateral testis? If the answer is yes, still, the recommendation is probably that you complete an orchiectomy on that person. It's going to give you the best oncologic outcome, and be a very definitive surgery, and hopefully should minimize some of the issues they might have moving forward. However, if they do not have a healthy contralateral testis, then one of your options you can do is to try to attain negative surgical margins that you confirm via frozen section. If you're able to do that, you can also perform biopsies of that testis to look for germ cell neoplasia in situ, and that can be something that can be done more in the final pathology. And then you can continue along with your partial orchiectomy. So this can be something that you can still offer a gentleman, even if you're coming back with a positive frozen section in these scenarios where you might render someone without any testis tissue after the surgery if you did a completion orchiectomy. So let's go back to our case. So we bring up these options to our gentleman, suggest that a partial orchiectomy would be maybe a good option for him if he wants to maintain some testicular function, which he does. However, he has some concerns about all this decision making we're going to be doing intraoperatively. It's based all around this frozen section. He questions how accurate frozen sections in this scenario are, as our decisions appear to entirely hinge around this process. Well, all the major guidelines do provide some general advice if you're going to offer this procedure. And they kind of say all sort of similar versions of the same thing. So they say either, have a dedicated GU pathologist review the frozen section, or don't perform this type of testis sparing surgery at centers without a dedicated GU pathology team, with the idea being to try to reduce the chances that you're going to have, a false negative or a false positive in these scenarios. In regards to the accuracy, it appears that we're pretty good. So this is one of the largest studies that was looking at men who underwent partial orchiectomy and then looked at the intraoperative frozen section and then the final pathology. And this was about 144 guys. So it's a bit of a confusing table here. This is just split between the lesions that ended up being malignant or benign. You can see here that in terms of the sensitivity of picking up a malignant lesion, we're certainly not at 100%. So unfortunately, we are accepting a slight chance of having a false negative by relying on that intraoperative frozen section that's driving our decision making, but it's okay. So I think it's something that can be counseled to patients, that it's a possibility of having that happen. But with a good GU pathologist, hopefully that would be something that would be relatively minimized in this scenario. So after we discuss, the nuances of a frozen section with our patient, and they say they're ready for the OR, is there anything else we really need to counsel this man on prior to him undergoing, a partial orchiectomy? And the answer is yes, and this goes for all patients, whether or not they're undergoing a partial or radical orchiectomy. And for the fifth year studying for their exams, is a good, short, very easy list to rattle off. If you're doing an OSCE on testicular cancers, you can offer it to everyone. Every single man who's undergoing an orchiectomy needs to be offered sperm banking and cryopreservation. And if they ultimately are undergoing an orchiectomy, a radical orchiectomy, they should be offered a testicular prosthesis insertion, or planning if you needed to do that in a partial scenario where you might ultimately proceed to a radical orchiectomy. You know, documentation of offering these is quite critical, as you really, really do not want to have these men coming back later in time saying they weren't, you know, told that they could do sperm banking, and now are infertile. And I can certainly say clinics, we do see guys 10 or 15 years out from other types of surgeries or treatments that have rendered them infertile who quite regret not sperm banking at that time. And so this is something to document in their chart that you offered them, and if they refused, so that at least in the future you know that that did occur. So most guidelines would suggest that only someone with, you know, a dedicated interest in partial orchiectomy should be doing these procedures. You know, but honestly, the surgery itself is pretty straightforward. I bet even our oncologists could learn how to do it. And so I'm going to quickly walk through with some operative photos here of how we do sort of a partial orchiectomy, as it's really not the most difficult procedure. So you would really just start, you make your normal typical inguinal incision, gain control of the cord as you normally would. And then here, we're just opening up the tunica vaginalis. And then sometimes you're actually able to palpate that mass that you maybe weren't able to palpate when you're doing a scrotal exam. Now that you actually have the testes sitting, you know, right between your fingers. And you can make an incision right over the mass if you can palpate it. If you can't palpate it, then you can just make an incision to look and see if you can find it. Sometimes you do have to use things like intraoperative ultrasound, et cetera, to actually find the location of quite small masses. Once you've identified the tumor, either via palpation or intraoperative ultrasound, then you can split the normal tissue, testes tissue, away from the mass, especially if it's benign. But even in some of the malignant masses, I think you'd find that the testes tissue comes away pretty easily, at least easier than you would think. It's not necessarily as stuck down to it as you might expect. So actually performing this step and isolating the testes mass is actually relatively easy. Once that's done, you can excise the mass. You split it, send half for pathology, half for frozen section. Then you wait for your frozen section results to decide, based on that decision tree we were talking about what to do next. Typically, any of this bleeding that you might encounter after you've excised this mass, you know, you try to use bipolar to really limit damage to the surrounding testes tissue and any of the blood supply that might be present. So now back to our patient. So our patient's made it through his partial orchiectomy. Review his pathology shows it is, unfortunately, is a seminoma, negative margins. We did take biopsies at the time for GCNIS. They all come back negative, which is great. He would now like to know what his expected outcomes are regarding survival and local recurrence, because now he unfortunately does have a confirmed, you know, germ cell tumor. Well, although we don't know a whole lot about small testes masses, we've actually been doing testicular sparing surgery for quite some time. So the first case report of this was in 1982. There was a gentleman who had a metachronous seminoma removed via testes sparing surgery. Kind of strangely, they had to undergo an orchiectomy 6 weeks post-operatively due to an infection. But that gave the authors the opportunity to look at that testes on pathology to see if any residual tumor was noted, which it wasn't. So short follow-up of 6 weeks, but it did look like the first attempt at testes sparing surgery, at least surgically, worked. The largest series for us to actually look at outcomes comes out of Germany. There's 101 men enrolled with both non-sem and seminoma testes tumors. All were actually offered adjuvant radiation post-operatively. And they seem to have excellent cancer-specific survival at a pretty long follow-up of 80 months, so 99%. They noted 6 men had local recurrence out of this 101 sort of cohort. But importantly, 4 of those 6 were men who had actually refused adjuvant rods afterwards, and we'll get into why that's an important thing to offer our patients. So what do we need to offer our patient now? So he has seminoma, he had negative margins, let's say he has negative markers. Do we put him on just a typical testicular cancer surveillance protocol? Do we offer him something like chemotherapy? Do we give him radiation? Well, most protocols, and these are endorsed by at least the European Urology Association guidelines, would say that if you're doing a partial orchiectomy with a confirmed germ cell tumor, you should probably offer them adjuvant radiation, and they use the very clear wording of at some point post orchiectomy. And we'll get into why that's actually probably the correct wording to use for these gentlemen. So what would post-operative radiation do for these patients? Well, from a fertility perspective, it's certainly going to lead to irreversible infertility. Almost all these guys will develop, a Sertoli cell only histology afterwards. And about 25% of guys are going to need some type of androgen supplementation after they undergo this type of radiation. And so we might be now asking, well, why do we even need to do radiation? It sounds like it's pretty much just as bad or close to being as bad as just doing an orchiectomy for this person. Well, first remember, this is just being given to guys with confirmed tumors. So we've avoided this in anybody who has a benign tumor. So we're giving this to just a small subset of men. So in the guys we're not giving it to, we've avoided this entirely. However, in the guys with cancer, what we really care about is this germ cell neoplasia in situ. So this is something that we're going to be trying to go after with that radiation. And the reason we need to give that rods is we know that GCNAS is really common around these testes tumors. So in most, at least of the case series that have been reported, they can find GCNAS in about 70 to 80% of guys sort of directly around where the testes mass was excised. That's why doing some of those biopsies is important, at least for prognostication. And why we care so much about GCNAS is we know that if a guy has it diagnosed in a testis, they have a 50% chance of a tumor recurrence within a relatively short time, 5 years, if that GCNAS is present. So that's what the radiation is going to be going after to try to eradicate the presence of any of that GCNAS. So we break the news to our patient. We say, listen, we're going to have to send you to see, radiation oncology. He's understandably pretty upset because he was thinking about maybe having some children. And we've just told him that this radiation is going to render him potentially infertile or almost certainly infertile. So how should we manage this request for fertility? So now I'm bridging oncology back into something that I'm a bit more comfortable with. So we basically have a couple of options that we can offer this gentleman. And this is why that wording of at some point after surgery really comes into play. Because really this can be thought of as kind of, slightly like prophylactic radiation, where we're just trying to get rid of any of that GCNAS that is probably present. But we do have some time. This isn't something that necessarily needs to be done immediately to get the best oncologic outcomes, at least based on our current data. So there's essentially sort of 3 different scenarios that we can offer this patient, or 3 scenarios that a patient can fall into. So the first situation, similar to this case that we've created here, which is a patient that wishes to father a child in the short term. So we define short term as probably months to sort of 1 to 2 years at the most. So in this scenario, what you're capable of doing is deferring radiation. They can try to naturally conceive. They should be counseled to be banking sperm anyways, sort of right away. You'd still follow them along very, very closely. And if they're able to father a child in this time frame, that's fantastic. If they're not, then you would be recommending that they undergo radiation and use that sperm that they've hopefully banked to still be able to pursue fertility with assisted reproductive techniques. The second situation would be someone who wishes to father children years later, so they don't have any plans in the short term. You tell that person just bank sperm. We'll delay radiation just by a little while, a couple of months, to allow you to do that sperm banking. Then we'll give you radiation. And then the third scenario would be someone who has no desire for children, and you can offer them radiation up front. What's important is really to counsel that situation 3 patient to bank sperm, even if they say they have no desire for children, and really document if they say they do not want to do that you offered it. Because again, like I said, we've had many men sort of coming back 10, 20 years after they've had some type of treatment that's led to them being infertile, who really regret their decision to not bank sperm. And the guys who do, we have a fantastic solution for them moving forward from a fertility perspective. And importantly too, we really can't forget surveillance because this person is essentially a man who's now been diagnosed with a germ cell tumor. So even if he does undergo adjuvant radiation therapy, they still need the exact same ongoing surveillance for this disease. And at this point, we don't really deviate any different from the surveillance protocols for any man with a germ cell tumor that's been diagnosed. So I've just cut out here sort of the AUA recommended follow-up of clinical stage 1 seminomas for a patient like we presented here today. But that's very important to remember. We don't treat them any differently afterwards, so they still have to have the typical follow-up, not more intensive or less intensive than gentlemen with a germ cell tumor. And so I'll sort of finish off this round with a quick plug for some new technologies that we should have at our disposal soon. So really where the biggest diagnostic dilemma occurs with these small testicular masses is that initial phase. So when that patient first comes into your office after they've had this ultrasound for some other reason and has now been diagnosed with a small testicular mass that we don't know if it's malignant or not. We don't know necessarily what to do for that gentleman. And so there's newer ultrasound technologies, one of them being multiparametric ultrasounds that actually tries to characterize a testes mass sort of by the hardness or elasticity of that lesion. That lets them make a prediction as to the risk of malignancy. So this maintains the same sensitivity as an ultrasound. Ultrasounds, like I said, we're already very, very sensitive at picking up testes masses, but it bumps our specificity up from well below 50% to upwards of 80%. And so that's something that might allow us to kind of risk stratify some of these patients, identify those who maybe would benefit from sort of upfront surgical treatment, and those that can quite safely be put onto an active surveillance protocol. And that's it for me this morning. Thank you very much, everybody.